So just one elbow by your side, then to 90 degrees. Excellent.
Given humans' instinctive response to protect themselves, hands are the most commonly burnt area of the body and can have a detrimental impact on long-term function. Therapy is therefore imperative. This video will outline principles of hand burn recovery, including exercises, edema management, splinting, and return of function and independence. Active movement and functional use of the hands is encouraged early in burn injuries. If grafting has been required, there is generally a 3 to 5 day period of immobilisation for the graft to take. However, delaying movement and function complicates recovery both in the short and long term. It is vital for clinicians to educate their clients on the importance of moving their hands and engaging in therapy sessions, and to also alleviate any concerns they may have of making the injury worse. When it comes to function, if they don't move it, they lose it. Active tendon gliding exercises minimise edema and prevent tendon adhesions. They are generally prescribed for clients to perform until they achieve and maintain full active movement and function. MCP flexion and extension. Keeping the distal and proximal joints straight, flex the MCPs as far as possible and hold for several seconds, before then extending. Providing some support in the palm can assist the client to achieve greater flexion at the MCPs. PIP joint flexion and extension. Keeping the metacarpal straight, the client aims to flex the proximal and distal joints into the palm of the hand. Blocking the MCPs can allow for a greater stretch and movement at these smaller joints. Abduction and adduction. Keeping all joints straight, abduct the fingers wide so web spaces are stretched. You can see here when the client is adducting their fingers, the little finger is already being pulled into abduction by the developing scar of the ulnar surface. Watch for trick movements by the client. Here, they ulnar deviate at the MCPs as they try to adduct the little finger. With the hands pronated, clients can aim to perform an L or a backward L to maintain thumb web space stretch. Oppose the thumb to the tip of each finger to ensure O shapes are formed by the thumb and each digit. Avoid clients using compensatory movements, such as bringing the thumb to the lateral side of the fingers rather than the tips. It is important for any burn covering a joint, even if this is a single joint, that composite movements are completed to place joints in a full stretch. In dorsal hand burns, concentrated efforts in flexion is required, whereas palmar surface burns require focus on hand extension. This aims to elongate and stretch the surface of injury. Again, watch for the subtle compensatory movements. Seen here, when the client curls his PIP and DIPs, the MCPs slightly extend, creating more of a hook fist as opposed to a tight full fist. Placing pressure over the dorsal fingers by either the clinician or client enables a deeper stretch and correct full fist movement. To begin with, each hand exercise can be repeated 10 times every 1 to 2 hours, and adjusted depending on client and therapist. As range of movement and function increases, repetition of these exercises can be reduced. Where hand range may be limited and a client is reluctant to push their movement, a passive assisted stretch for 30 to 60 seconds over the affected area by either the clinician or the client may assist with increasing joint range of movement, scar length, and desensitization to the recovering skin. Ensure care is taken not to damage grafts. If left untreated during the recovery stage, edema can result in increased fibrotic tissue, reduced movement and function, and increased risk of scarring complications. A number of modalities of treatment can assist with minimising edema during recovery. Combining all modalities is most effective. To prevent the pooling of edema in the back of the hand, the extremity can be splintered in the position of safe immobilisation, with IP joints extended, MCP joints flexed to approximately 70 degrees, and the wrist in 30 degrees extension. Elevating the affected hand on 2 pillows overnight and during rest periods allows gravity to assist with the return of fluid and supports the venous and lymphatic systems. Advise clients to minimise time in dependent positions, such as walking with the hand down by their side, which can create pooling of fluid. Clients can perform their tendon gliding exercises whilst the limb is above heart level. The use of light compression, such as isotonic gloves, Tubigrip, or circumferential bandaging, works by reducing space available for edema and supporting the circulatory system. For grafted hands or slow to heal hands, static splinting during recovery can minimise contracture formation and protect anatomical structures. Splinting is most effective in the first 6 months when scar formation is most active. A variety of splints can be used depending on the hand burn injury. 2 examples include Palmer burns, which are generally splinted into extension and abduction using a pan splint to the volar surface. Dorsal burns, which are splinted in the position of safe immobilisation. Alternating splints may be required if a client has burns to both surfaces of the hand and therefore requires a slow stretch to both of these surfaces. Splinting the hand for extended time periods, such as 6 to 12 hours overnight or during rest periods, provides opportunity for tissue to elongate and range to therefore improve. Balancing splinting with activity and exercise is imperative to keeping the hand moving and to regain function. As range of motion increases and function improves, the time frame for splinting can be reduced. Following the principles of scar management, clients may have pressure gloves provided by the burns unit clinicians to assist with their pan burn recovery. Refer to the scar management video part 2 for details of use and monitoring. Integrating the hand and body is essential to increasing independence and enabling return to usual occupations. Clients must be encouraged to use their hands in daily activities. Tasks may start small, such as eating and drinking. However, goals and therapy intervention should be graded throughout the recovery process and tailored to occupations important to the person. The overall aim is for return of full function in all of the client's activities. Hypersensitivity and reduced tolerance to tactile stimulation is a common complaint post a hand burn injury. Activities and movements that gradually increase tactile tolerance should be encouraged. Examples include drying hands on different textures of towels, becoming confident with self-touch over the scar with different pressures, manipulating a range of altered textures and surfaces, with the aim of building up tolerance of touch to re-engage in all gross and fine motor activities.